Respected senior consultant and dear friends, it will be a pleasure. Thank you very much for the wonderful opportunity for team video gave me here. And today we are here to take on the discussion with capsule endoscopy. And my role is the various types and how to do the capsule endoscopy. As already been discussed, the capsule endoscopy right now being taken a major innovation in the field, mainly to avoid the small bowel lesions. Apart from that, there are three major things we should not forget. In capsule endoscopy, already the previous speaker, I think most of the things being discussed. My intention to brush up how are you going to do the procedure and what are the key findings you need to do. When compared to other innovative models, the newer one, in what way it is going to differ you and how are you going to proceed and how are you going to monitor the patient when you are going to do the capsule endoscopy. That's the main area to take on with the discussion. The first and foremost is your pill cam by Medtronic. That will be divided into three major types. Four. One is by your esophageal capsule, another one is by small bowel, and another one will be by your colonic capsule, and another one will be by your pan-colonic capsule, mainly for the Crohn's disease surveillance. And this Mevacam will be having a potential long battery life, and apart from that, now O-mount device has also been available. It's mainly manufactured in the Indian market, with Asian, not in Asian market. So it's mainly helping contributing with a reasonable cost in order to have a long battery of life like a Mevacam. And apart from that, so this is all the basic outline will be flowing in. Already these slides have been discussed by a previous speaker. And very importantly, we should remember that the LED soap, the aspirate, the lens, the flow of dynamics, the signal flow once it's going to hit the light, lens, your CMOS, which means your complementary metal oxygen sensor with your application specific integration circuit, once it's going to get activated, in which the flow will be in your antenna. And the sensor, like around 7 to 8 sensors in which you are going to place in the anti-abdominal wall. So the data is going to record and the workstation flow is going to take on with this basic architecture. So what is the main thing? The pharyngeals, once you're going to enter the pharynx, once you're going to swallow, after the esophageal transit, then your small bowel, gastric transit as well as small bowel, as well as in the colonic transit. So you should remember that. And almost the entire length will be around 10 meters, in esophagus will be around 25 to 30, in small intestine will be around 6 to 7 meters, and large intestine will be around 1.5 to 2 meters in region. So pill cam has the three technical specifications already been done. So mainly remember this very simple thing, and the diameter usually will be around 11, the length will be around 23. But usually in 11.5 will be in colonic capsule will be the diameter, and the length will be the bigger brother. So almost around 30 millimeters will be the length of the colonic capsule. So usually 22 these things we should not forget. And apart from that, pill cam cones and already been discussed. This O-mount device, the main thing is the battery of life will be almost around 8 hours, the 150, 140 degree field view and all these things. So Mevacam is one thing in which a newer innovative signal. Rather than the radio frequency, here the human body communication is being applied when you are going to use the Mevacam, and the extended battery performance will be there. So the Mevacam, your pill cam, as well as your O-mount devices, all these things is mainly being aided to diagnose your small bowel lesions. And this Mevacam, the main intention to look for that when your patient is having any slow transit events, or the patient is having gastroparesis, in which we need a more validated, more time controller, then we can use this Mevacam device. Capsule cam already been discussed, panoramic view, almost around 360 degrees view, in which we are going to use the 4 cameras and all those things, complete mucosal visualization in order to detect everything and reduce the missed lesion and capsule will required for image and all those things. This pill cam column 2 is very important. The diameter is almost on the higher side, already been discussed, 11.6 into 31.5, and in which for this we need the enhanced aggressive bowel preparation, and we can use this for complete identification of your various stricturous lesions. See, colonic capsule mainly for difficult anatomy, if it's very difficult patient, hemodynamic, not stable, and in the background of high risk patient, the anesthetic risk patients, along with colorectal cancer surveillance, and if the patient is having any difficult anatomy or any very strictures and patient intolerance, all these things you need to be very cautious when you're going to do that. Esophageal capsule is one important, very mainly for your varicose detection along with your Barrett's esophagus screening. So what are you going to do for this varicose detection of Barrett's? Apart from the positioning and manipulation is very important for the esophagus. Always the esophagus will be having a very short transit. It will be less than few seconds, well 15 to 20 seconds it will usually take transit. So what we are supposed to do, we need to make the position supposed to be changed once the patient is going to have a swallow. So make the patient flat, initial phase, and ask the patient to swallow very little liquids. Around 10 to 20 seconds, ask the patient to take very limited swallows of liquid, 15 to 20 ml of water. Along with that, ask the patient first to be in flat position for 2 minutes, and then you need to make the patient to be in supine position in a 30-degree recommend for another 2 minutes, 60-degree recommend for another 2 minutes, and 90-degree recommend for another 2 minutes. Like that we need to flow, and within 15 to 30 minutes usually the procedure will get complete, and the battery of life also will be very short, within around 15 to 30 minutes when you are going to use your esophageal capsule. Already we discussed the pan-entry capsule for Crohn's disease, in which ingestion, your transit and assessment, the complete starting from a small bowel to large intestine, the complete transit assessment by your pulmonary capsule. And the pan-entry capsule is mainly to identify the strategies, pediatric monitoring, post-surgical surveillance. You need to map the disease, for which you can use the pan-entry capsules. Nowadays, other new innovations in which not been discussed in the previous thing. So magnetically controlled capsule endoscopy, in which your hand-con navicon has been tried, in which what we are supposed to do, the physician enables a real-time physician-directed navigation of the capsule. So what are the major indications? The magnetic guidance system controls the capsule position, and the complete gastric mucosal mapping will be happening within around 15 to 20 minutes. No major sedation required, and it can be performed in outpatient setting. This MCCE, the role will be in gastric cancer surveillance and non-invasive assessment for esophageal Diagnostics as an alternative we can use in the background of a high-risk bleeding patient, anticoagulant or severe cardiopulmonary disorders, and research application for gastric motility assessment and all those things you can use your MCCE. And artificial intelligence always will be having a height. Once you are going to combine with your PDCAM and all those things, there will be having evidence to identify more of angioplasia, ulcer deletion, stenosis, polyps, and all those things when you are going to use your artificial intelligence combined. Two major platforms been identified. One is your Medtronic as well as your Wormhome, in which Wormhome, as we have already discussed, is an Asian-based device in which we can try into it, and third-party solutions are also there to look for your AI platforms to identify and to integrate the findings when you are going to look at it. What is this patency capsule? See, always we cannot use the normal capsule for all the patients. A patency capsule means it's easily dissolvable. Once, if you're going to swallow within 30 minutes, usually as the time progresses, it will get dissolved, and within 30 hours, it is going to get excreted. Suppose if you are going to identify any stricture lesion, any stenosis presentation, when you want to be cautious, when you want to take a prior safety means, we can use a dissolvable capsule, what is called as patency capsule, will be very safe. The suspected of Crohn's in the background of small bowel obstruction, any prior radiation, any NSD antibody, or in the background of small bowel tumors, you can use that. So what is going to happen when you are going to use this capsule? The barium and lactose body will be there. It will be attached to the radio frequency tag for detection. So it dissolves after 30 to 40 hours if it is going to retain. So there is no major worries when you are going to use this kind of capsule in the background of stenotic lesion. So with this picture, we can able to identify the ingest capsule, the tag will be retained. We can able to identify that. The scan we need to do at the end of 30 hours, and we need to see whether the excretion is intact or not once the patient is going to go for patency capsule. And nowadays, even the newer capsule technology being trying, innovation, all those things happening, drug delivery. So directly we can be able to, for example, in the case of IBD, if you want to detect the system directly, we can deliver the drug. That's pH sensitive, time control release capsule being tried. And biopsy. Suppose if you are identifying a lesion, ectasia and all those things, if you want to take a biopsy in those things, various centers, they make an attempt for microbiopsy capability, and we can go for biopsy capsules, self-propelled capsules, in which the extended examination time and targeted lesion inspection we can use for self-propelled capsules, mainly for research purpose. What are the newer next generation capsule innovations? One is by real-time viewing system, in which by the time when you're going to do automatically, simultaneously, we can able to identify what is happening in the gut. Rapid assessment we can do by a real-time viewer, and therapeutic capsules in which bleeding control, ectasia management, and targeted management, cauterization, all these things we can try. And global research initiative mainly been happening in Japan, South Korea, and European centers with this capsule endoscopy innovations. The retention risk, not in patency capsule, the other capsule almost around the general population will be around 1 to 2%. So in Crohn's, if you are having any structural lesion, there will be around 5 to 30% of the population, there might be evidence of retention risk. So very importantly, the procedure, what are you going to prepare? So always make the patient should be in the for esophageal capsule, the patient supposed to be in the at least 2 to 4 hours, no major. Some patient we can apply first 4 to 6 hours also. And esophageal capsule, mainly as I already discussed, various positional change, we need to look into that. And apart from that, within 4 hours, everything will get complete and we can get back. And within 30 minutes, most of the time, the battery of life will go down with esophageal capsule. But what about the preparation? So the main thing is fasting 2 to 4 hours for esophageal capsule. What about for small bowel capsule? Small bowel capsule is mainly around 6 to 8 hours of the transit, that's all. And the battery of life will be around 8 hours. That we need to look into that. Apart from that, fasting around 8 to 12 hours. And bowel preparation around 2 liters of PEG solution we can use, 1 to 2 liters, no major than that. Simethicone, metoclopramide, all those things, prokinetics, all those things you can add to prepare the bowel. Colonic capsule is always a difficult task because most of the time in small bowel capsule we need to focus that once it's going to reach the cecum, that means the first study is almost get complete. There is no intention to look for the complete excretion. But because the complete excretion process will be taking 24 to 48 hours or 48 to 32 hours, some patient depends upon the viability. But for colonic capsule, mainly it should be, the bowel preparation should be aggressive. We need to give 4 liters of bowel preparation and make sure that the cardiac status, everything is supposed to be done. And during the procedure, intervening at the time, when after 68 hours also, we can augment, that's called booster preparation. We can give another sodium phosphate or 1 more liter of PEG solution to the patient, because that will be a so for the colonic capsule, we need to have a battery transit which will be maintaining almost around 12 hours to maintain. That's how we need to identify a colonic capsule. And the complete procedure will be taking. So until you are going to finish a colonic capsule, the patient is supposed to be nil by water. It will take not nil by water, clear liquid diet. But for small bowel capsule, initial phase 0 to 2 hours, no major diet. After that, 2 to 4 hours, you can give a clear liquid diet. And after 4 hours, you can give a light snacks and light meal. That is how we can take on with this capsule endoscopy preparation. This is what the sensor placement, device activation, ingestion, and we need to properly document. So all these things, and as I already discussed, the transit time is very, very important. Esophagus, stomach, bowel, colon will be variable. The battery of life will be predominantly in the range of 8 to 12 hours. And small bowel will be around 3 to 6 hours, and colonic will be variable, usually around 48 hours of transit time. So this is the basic outline what you're supposed to do. Always for esophageal capsule, the cameras will be around 2. And in small bowel already we discussed that Capsule will be having 4 cameras in which the panoramic view we can able to identify. And usually the completion will be EKG screening, cecum if it is reaching by the small bowel, and excretion which is being adequate rectum. Because the problem is even colonic capsule, the stools and all those things will be having difficulty most of the time. That's why the aggressive bowel preparation needed when you are going to look for the evidence of your colonic capsule. And this is all the basic outline, what you're going to do, all the procedure, the snack, the diet, the recording. So capsule endoscopy, be very conscious, make sure that the patient is going to excrete within 48 to 30 hours, the capsule has to come out. That is how we need to diagnose. And apart from that, we need to look for caches. If the patient is not passing within 72 hours, which means the capsule retention will be in the higher risk. So we need to be very cautious to that kind of patient. Apart from that, this is how we need to proceed with the basic surveillance and screening for your small bowel capsule endoscopy. Thank you very much.